this session, Dr. Sridhar Sundaram. He is a consultant neonatologist and head of neonatology at Perinatal Emirat Hospital. And he will talk about perinatal asphyxia and anaphreo. Dr. Sridhar, the floor is yours.
Thank you. I think I'll share the screen, and I would like to thank the organizers for inviting me, and thank you, Dr. Ali, for the kind introduction. Are you able to see my screen now?
Yes, yes.
So, good afternoon, everyone, and I would like to thank the organizers again for accommodating the slight change in schedule and appreciate that. Perinatal asphyxia is a very important topic, obviously, and it's important both for the neonatologist and for the obstetric team. It's very stressful for the obstetrician who may encounter a baby who needs resuscitation at birth. And so it's a combined management, and the communication needs to be very clear from the start from both sides as well. Just to give you the background, I mean, this is the fetus with the placenta and the combination of the mother and the fetus, feto-maternal unit. So it's a very unique relationship between the fetus and the mother. As you know, the labor is a very stressful period. The blood vessels of the placenta are going to be constricted, and it challenges this relationship. So there is a reduction in the placental flow during the contractions, which reduces the efficiency of gas exchange. The relaxation in between the contractions allows the flow to improve. But as you know, we have many parameters which affect the progress of labor. The syntocinon that we may use to augment the labor, the speed of progress, the descent of the baby, the force of the contractions and everything. If there is a sign that the fetus is not tolerating, that's why we have the monitoring of the fetal condition, CTG, if you're listening to the fetal heart rate and everything. If there is any sign, you try to reduce this by improving the maternal posture, side lying, which reduces the compression of the IVC in the mother, improves the blood flow, and improving the maternal oxygenation, which may improve the oxygenation in the fetus. And if the mother's blood pressure is low, correct the cardiac output. So this is fetal resuscitation, which is the first step when you think that the fetus may have less tolerance of the labor process. So what are the problems that can be encountered during the labor process? It can be a prolonged labor. This can happen because of the cephalopelvic disproportion, or the contractions are not happening properly. The contractions are too strong or too frequent. And when we use a medication, we should be very carefully titrating the dose, and that's why it's very important that the midwives and the nurses are closely monitoring the fetal heart when the drugs are increased oxytocin. And if the fetus is compromised due to growth restriction, which itself may be a sign of placental insufficiency, the tolerance of the labor process will be poor. We may also have infection, which may affect the ability. It reduces the fetal reserve to tolerate the labor, so the baby has a higher chance of not tolerating the labor process. There may be obstruction to the cord as part of the progress of labor. You may have cord accidents, cord prolapse, a knot in the cord compression, and we may have abnormal separation of the placenta, which is abruption. The factors can be classified as maternal factors, which can be due to the maternal illness like severe PAH or preeclampsia, severe anemia or cardiopulmonary illness, which affect the gas exchange in the placenta, or any acute illness in the mother like septic shock, which can cause hypotension. The placental factors, as we discussed earlier, may include APH and abruption. It may be infection like chorioamnionitis, or it may be abnormal placentation. This is often seen in multiple pregnancies. And it can be fetal factors like IUGR, infection, antenatal insults to the developing brain. This is very important because that's an area where it clashes with postnatal assessment of the newborn's encephalopathy. If there is an antenatal insult like a porencephalic cyst which has damaged the brain, or the baby has an underlying metabolic condition, the baby may be hypotonic, it affects the tolerance to labor as well as the baby's response after birth. Baby may need resuscitation because the baby has hypotonia already due to brain injury, and it may get attributed to birth asphyxia. So it's very important how we document the settings around birth asphyxia. Is it really birth asphyxia, and so on, as we will see in the coming slides. All of you may be familiar with this image of the diving seal, and the penguins share the same. It's nothing but what we call the diving reflex. So it's a reflex activated in animals like the seals and penguins when they dive into the cold water. And when the phase of these, birds and animals come in contact with the cold water, there is bradycardia and peripheral vasoconstriction. The circulatory diversion preferentially moves the blood flow to the brain, heart, and adrenals, the vital organs. And this is at the cost of the gut, liver, kidney, skin, and muscle. And as long as the baby is inside the water, this continues. So they conserve the oxygen till they come back up and breathe again. And the diving reflex applies in fetuses which are subject to asphyxial insult. And this has been demonstrated in animal experiments as well. And this is the reason why there is multi-organ dysfunction when there is relative sparing of the brain. So suppose you have time for the diving reflex to set in, it may protect the brain or relatively protect the brain, but the kidneys and the liver or other organs may take a hit. When there is acute total asphyxia, however, there is not enough time for the diving reflex to protect the brain. So you do get brain injury without multi-system involvement in these situations because the other organs have a higher threshold to injury than the brain. The brain gets hit very early if there is significant ischemia. So how do we define perinatal asphyxia? It is a state in which the placental gas exchange and the circulation are affected, leading to progressive hypoxemia and ischemia. And we have three characteristics: hypoxia or reduced oxygenation, ischemia or reduced perfusion, and acidosis, which is usually a result of these two, because when the reduced oxygenation happens, you go into the anaerobic metabolism, which produces more lactate, and the acidosis builds in. If there is a cord occlusion, then the CO2 retention happens as well, and it's a mixed acidosis in these situations. The incidence is variable. It depends on where you live in. This is the Western data, 2 to 6 per 1,000 live births. In the developing countries, it can be as high as 15 to 20 per 1,000 live births. And the risk of encephalopathy ranges from roughly 0.5 to 2 per 1,000 live births. But again, in the developing world, it can be as close to 10 per 1,000 live births. So it's a very big problem in the developing world where even the regular obstetric care is not available. There is a link between perinatal asphyxia and poor neurological outcome. And there is a resulting risk of litigation, which all the obstetric teams and hospitals are worried about. There are three main types. You can have acute total asphyxia. There can be prolonged partial asphyxia, and there may be an acute event overlapping on partial asphyxia. Even though we may not be able to differentiate exactly which category it comes in, the complex of issues that come up, the clinical presentation, the timing of onset of seizures, the findings on MRI, they may point the direction to which type this falls under. So acute perinatal asphyxia usually happens with a sentinel event. So most of the asphyxia in the developed world belongs to this category because there is very good obstetric assessment, there is close monitoring of the fetal distress and everything. So the interventions are taken on time. But when there is a sentinel event happening, it's very abrupt. You cannot always predict it. So this happens even in the developed world where there is good obstetric care. So prolapsed umbilical cord or cord prolapse is a very dangerous thing. Uterine rupture may happen suddenly, especially in a multigravida with previous cesarean. Abruption again happens as an accident, and acute blood loss from the cord can happen due to fetal-maternal hemorrhage or in twin-to-twin transfusion. There may be any condition that causes an abrupt reduction in maternal cardiac output. It may be a maternal illness, a maternal accident or injury, and this will affect the blood flow to the fetus. So as you can see, most of this we cannot predict. It's an accident of nature. And obviously, it can happen in any setup, even if the obstetric care is good. The key here is to recognize it early, and it's basically a matter of luck where the mother happens to be in the right place at the right time. So this is an abruption where there is a collection of blood behind the placenta, the retroplacental clot. When the placenta is lifted off, there is actually no effective gas exchange that can go to the baby, and so the baby is asphyxiated. A true knot is very rare, and sometimes a true knot may happen without really obstructing the flow. So again, it's nature's miracle. In the acute total asphyxia, the fetus is suddenly and rapidly deprived of his or her lifeline. The diving reflex is not activated due to the rapid insult. There is no multi-system dysfunction. The damage to the central brain is typical here, and it involves the thalamus, basal ganglia, and the brainstem. So these areas are key, and you may recognize abnormalities in these areas on the MRI scan, which is done by day 3 or so. There is usually sparing of the cerebral cortex because the cortex is affected by watershed infarct, which we will discuss in the persistent prolonged asphyxia. The survivors may develop the extrapyramidal type of cerebral palsy, the dystonic cerebral palsy, or the dyskinesia, and so on. So this is the reason the basal ganglia thalamus affects this tone mainly. So it's a dystonic CP that you get here. The prolonged partial asphyxia, on the other hand, there are lesions in the cerebral cortex in the watershed type of distribution. So same way the diving reflex is trying to protect the watershed area where there is a junction between the two blood vessels of the brain is the area where the blood flow drops first. And there is multi-organ involvement with active diving reflex in most of these cases. Because there is high amount of cortical involvement, you may have spastic cerebral palsy at follow-up. The cognitive impairment severity depends on the extent and severity of the lesion. Overall, it can be quite severe. You do see any case from hemiplegia, monoplegia, or spastic diplegia, or it may be a spastic quadriplegia with microcephaly. Many cases have an acute event overlapping on prolonged partial asphyxia. For example, I mentioned growth-restricted babies are compromised due to the placental circulation being affected, and they also tolerate labor poorly. So if there is an acute event overlapping, they will not tolerate it. This is an example of the cerebral blood flow, which is the lateral view of the brain. And you can see the watershed areas. This is the middle cerebral, anterior cerebral, and the posterior cerebral. And the opposite happens in the medial view, where it's the anterior cerebral artery which supplies most of it. And we have the posterior cerebral artery here. The middle cerebral artery surfaces mainly this outer portion of the brain. So the slight difference in the premature area is the significance of the periventricular area being the watershed area between the cortical segment and the lenticulostriate segment. So this is the area in premature babies where we typically get periventricular leukomalacia. So when you have asphyxia in a premature baby, you have PVL which progresses quicker than a PVL which happens in a very small preterm baby, otherwise progressing. So we say 3 to 4 weeks in these babies, but if there is an asphyxial insult, you may see PVL quite early in the course, like 1 week or so. How do we recognize whether there is asphyxia or not? I mentioned the example where a fetus may have a brain injury due to other factors and actually may not have asphyxia, but the baby doesn't respond well after delivery because of the underlying brain condition. So the correlative signs of asphyxia become important to differentiate a baby who had a pre-existing brain injury from a baby who is having brain injury during labor. It's not very easy to recognize that, but it's important to try and differentiate. So we may have meconium stained liquor, which may be a sign of fetal distress, where the vagal tone drops and the sphincter relaxes, the meconium may be passed. However, most of the meconium stained liquor happens in the post-term babies where there may not be any asphyxia. It's not a good correlate. The Apgar scores, as we will see, is not a very good correlate either, because it's a response of the baby to the resuscitation more than the underlying fetal symptoms. However, a prolonged or a high, a low of a 10-minute Apgar score is quite correlative of brain injury. The fetal and neonatal blood gas levels are important as well. Fetal heart monitoring changes. Again, it needs to be interpreted with caution. The neonatal neurologic syndrome and the occurrence of seizures are clear features that the brain has injury, but whether it's asphyxia that caused the injury depends on the other factors that are associated, the sentinel event or any of these abnormalities. Multi-organ dysfunction would go more with prolonged partial asphyxia that would correlate with asphyxia as well. And EEG and neuroimaging findings, even though not specific, it may guide you in the right direction. Because if you have diffusion-weighted changes like infarction in a brain which is otherwise normally formed, it may be fitting with asphyxia. The key reasons we look at these very closely is their medico-legal implications. As I said, once a baby has cerebral palsy, you want to see whether there was any association at birth which would suggest there was asphyxia or mismanagement during labor. And that's when these factors become important. In terms of the Apgar score, the correlation improves if the low score is persisting at or beyond 10 minutes. Thankfully, it's not very common. The factors, it may be affected, non-specific factors like prematurity, infection, congenital pre-existing problems, and neurological disorders. So the same reason the baby is floppy due to a brain disorder or a myopathy, the baby may not respond to resuscitation as well. It can be useful as an indicator of response to resuscitation and the adequacy of resuscitation measures. And it's very important to use the full range of the Apgar scores. You should categorize why you are scoring it when you document, so that in future, if there is any review, it will be clear. The blood gas levels have been used to monitor the fetal state in addition to the CTG since 1967, and metabolic or mixed acidosis is more significant. The neurologic outcome can be correlated with the severity and duration of acidosis, especially if the pH is below 7. There are, however, many babies who have a normal outcome below a pH of 7. So this is Goodwin et al.'s data, which clearly shows that when the pH is 6.9 to 6.99, only 12% of the babies have HAE. And if you have 6.8 to 6.89, 33%. 6.7 to 6.79. So this is a very low pH really. Even there, not all babies develop HAE. And as you go down, then the risk of multi-system involvement happens as well, because it's a persistent acidosis and it affects all the organs. So the correlation, the diving reflex doesn't protect beyond a certain time, because it's an indication of how long the asphyxia has persisted. So hypoxic ischemic encephalopathy is an important outcome we are looking for in asphyxia, because the most important, even though multiple or multi-organ dysfunction can be there, the most important long-term factor is the brain. That's why we are focusing so much on the brain in terms of asphyxial injury. So HAE is a clinical and neuropathological finding of encephalopathy that occurs in a full-term infant who has experienced significant episode of intrapartum asphyxia. So these are important. Intrapartum asphyxia is important. It should be documented as a significant episode, and there should be features of abnormality in the brain, both clinically and possibly on imaging. So we have the insult here, and the first thing that happens is a primary energy failure, which happens immediately. There is a sodium overload, excitotoxicity, and then there is immediate necrosis and cell death. And when the reperfusion happens, the cerebral metabolism transiently recovers. However, there is calcium overload, reactive oxygen species, and nitric oxide may add to the damage. And this is a secondary phase which lasts from hours to days, usually between 6 to 72 hours, when there is mitochondrial dysfunction and there is apoptosis, delayed cell death. So this is the reason for the hypoxic ischemic injury. The primary energy failure part, it's already done. We can't do anything about it. Most of the therapeutic interventions are between the insult to the first 6 hours. If you delay it too much, then the secondary injury has started and you can't really correct anything. So it's the reperfusion phase that we are mainly targeting for the therapeutic window, like cooling and other treatments we will discuss. The neurotoxicity happens from the release of excitatory amino acids in excess, like glutamate and aspartate. There is overstimulation of the NMDA receptors, and there is calcium influx into the cells as well. All these changes lead to accelerated apoptosis. So we have something called programmed cell death or apoptosis, which happens in all of us. Aging is the most important reason that apoptosis happens, and some of the organs, apoptosis is programmed. Like for intestine, for example, the intestines are formed as cylinders, and then the cells are lost in a systematic way. So it becomes a canalized version. So you have programmed cell death in all the tissues according to the purpose of them. Accelerated apoptosis leads to loss of these cells before they are programmed to die. So there is loss of regulation of apoptosis, and the free oxygen radical damage leads to significant injury as well. We may have hypoglycemia, seizures, hypotension, which are often associated with asphyxia, and these lead to additional brain injury. The multi-organ involvement thankfully doesn't lead to long-term impact other than very severe renal failure, which is not common, which can lead to death. So the organs affected: kidneys in 50%, brain 28%, heart and lung in 25% or so. The other organ involvement, like the liver, bowel, bone marrow, is quite rare, but you may get a transient hepatitis, a liver enzyme increase, or a direct hyperbilirubinemia, which is transient. The neuropathological changes typically seen in term babies include selective neuronal necrosis, which leads to spastic cerebral palsy, status marmoratus, which is typically the acute total asphyxia, chorea, athetoid, and dystonic CP, the parasagittal or the watershed brain injury, where you get spastic quadriparesis, and the focal and multifocal ischemic brain injury. This can happen in the acute on chronic or the total as well. This leads to cognitive defect, seizures, and hemiparesis. And in the premature babies, it's periventricular leukomalacia, which is typical. However, in a persistent asphyxial insult in the premature baby, the basal ganglia damage may dominate as well. So the classification of HAE can be either Levine's classification as mild, moderate, and severe, mainly looking at consciousness, tone, seizure, and the presence of sucking versus active respiratory response. So the mild, obviously, babies are irritable, hypotonic, there is no seizure in these cases, and the suck is poor. Seizures become moderate, and prolonged seizures or coma become severe. All of you are familiar with the Sarnath and Sarnath classification, and due to shortage of time, we'll not go into the detail, but you have stage 1, 2, and 3. Typically, stage 1, hyper alert with sympathetic overactivity. Stage 2 is hyporesponsive, hypotonic with parasympathetic overactivity, starting bradycardia, and so on. And you have stage 3, comatose. The seizures happen in stage 2 and may be persistent in stage 3. But if the baby becomes comatose and the tone becomes very low, you may have electrical seizures in these babies and not overt seizures. The management is supportive. You have to ventilate the baby appropriately, not to overventilate. Hypocapnia can damage the brain as well. Restricted IV fluids is typical because the renal function may not be normal and fluid logging may happen. There is also a risk of hyponatremia from SAADH. We should be careful with the temperature care. Avoid overheating. So the passive cooling concept is coming in, but we should be very careful that till we decide that the baby needs to be cooled, avoid hyperthermia rather than actively cooling the baby to a cool degree, because cooling also drops many of the vital parameters. You should be careful that you're monitoring carefully. So the more important thing is to avoid overheating. So you may reduce the heating setting, monitor the temperature, keep it around 36 degrees or so till you decide on cooling. Don't cool down rapidly when you don't decide, because the assessment of the baby's neurology will be affected by the temperature as well. Antibiotics are usually given where there is a setting, and regular monitoring is important. Control of seizures as they happen and CFM monitoring are very important. CFM is not essential, but it's a very good support to the treatment, and it's important for the seizure management because most neurologists suggest treating based on the EEG even if there are no clinical seizures. Therapeutic cooling is obviously a very important parameter in terms of treating such babies. There are 11 RCTs in the Cochrane review, and there are more studies coming up as well. And it's usually in moderate to severe encephalopathy with evidence of intrapartum asphyxia. Most of the studies use the same criteria we will discuss next. Therapeutic hypothermia is beneficial to term newborns with HAE, and it reduces both the mortality and major disability with the number needed to treat of 7 babies to gain 1 baby with improvement. So the benefits outweigh the short-term adverse effects of cooling. The AAP statement, as well as many other bodies like the CPS, bring out statements which correlate mostly with these criteria. There will be subtle variations, and you can have guidelines in your unit according to the setting as well. So a pH of less than or equal to 7 or a base deficit of more than or equal to 16 millimoles in a sample of cord blood or neonatal blood obtained during the first hour after birth. The history of an acute perinatal event is very important. So it should not be a baby who just was floppy at birth without any setting. It was elective cesarean, for example, then it's unlikely to be birthasphyxia related. A 10-minute Apgar score of less than 5 for assisted ventilation initiated at birth and continued for at least 10 minutes. So the need for significant resuscitation and a neurologic examination demonstrating moderate to severe encephalopathy is essential. So the sentinel event or an acute perinatal event and the neurologic abnormality plus the need for significant resuscitation and documented acidosis. The studies were using the amplitude integrated EEG as a criteria, but since not all units will have it, that's an additional parameter. So it's a useful tool. The key points to remember, it's very important to start it within 6 hours. And I described the passive cooling part. We should be careful not to allow it to interfere with your neurological assessment. Where the progress is clear, don't delay starting of the cooling. Mild encephalopathy can progress, but if it doesn't and stays mild, it's still safer to maintain cooling because we don't know the impact on the future, and we may get blamed if the baby has a neurologic injury in the future. So once you start cooling, that way is you continue cooling. The target range is 33 to 34 degrees for 72 hours, and you rewarm after that over 6 to 12 hours. There is no evidence, and actually some evidence that prolonging the cooling may harm. Cooling in the extreme premature babies or below 34 weeks is not recommended. There are studies in the borderline preterm babies. The relative contraindications include severe pulmonary hypertension, severe coagulopathy, severe cardiorespiratory compromise. So if any of these happen, they are relative contraindications. So if the baby happens to be on cooling and these complications arise, if you're unable to manage them successfully, you can rewarm the baby before the 72 hours. So it's a life and death question. Then you can rewarm the baby rather than continue because it may worsen these settings. The controversies related to mild encephalopathy, though many people are erring on the side of caution in mild encephalopathy, there is no evidence that it may help. Of course, it's very difficult to measure because the outcome is already good in mild encephalopathy. The difference will be difficult to show. And borderline prematurity, 34 to 36 weeks, what do we do? Many people are erring on the side of cooling, especially in the babies who tolerate it, where the weight is more than 2 kilos. There was a recent article, the Helix study by Sudhin Tayal et al., which was very controversial in terms of saying that you shouldn't cool in the low and middle income countries. There's a lot of criticism, and I have contributed to the criticism as well in saying that you shouldn't generalize a finding. This was done in government hospitals, which low income people attend. And there are many private setups in the same countries like Egypt, Pakistan, India, where you have better setups which can manage these babies similar. There is also a higher population incidence of partial prolonged asphyxia, where the asphyxia is not clearly documented. So you cannot extrapolate the findings. Where there is acute total asphyxia, where the cooling is more likely to help, because if the brain injury is already established, these babies had early seizures, which indicates partial prolonged asphyxia. So you may have missed the boat by the time they present to you. The newer interventions, drugs that may produce a synergistic neuroprotective effect with hypothermia. You may have anti-excitatory or anticonvulsant drugs like phenobarbital and xenon. Anti-apoptotic like erythropoietin, this is being studied with great detail and there is some benefit shown. Anti-calcium drugs like xenon, which is an inhaled gas. Anti-inflammatory or anti-oxidative drugs, melatonin. So there are many studies on melatonin and erythropoietin, which are looking along with cooling with positive results. You have neurorestorative. Erythropoietin has some neurorestorative function as well, and mainly it's a cord blood and mesenchymal stem cells. These may promote the neural regeneration and neurovascular remodeling. The stem cells may replace the neurons that are lost due to brain injury, and they may activate the endogenous stem cells and release growth factors that may help to repair and restore. There are some useful data from China which show benefit, but it's still in the experimental stages. You may instill the stem cells intranasally, and they may go through the oligodendrocytes into the brain and help with this repair process. Last couple of slides, neuroimaging. Cranial ultrasound has false positive and false negative results. You may pick up cerebral edema, and intracerebral hemorrhage due to difficult delivery may be picked up. The resistance index less than 0.55 at more than 24 hours is a poor prognostic factor. It shows that the autoregulation of the brain is not functioning. MRI is the most informatory tool, though it's not always available due to resource limitation, and it's difficult, challenging to do it very early. If you do it very early, diffusion weighting may show infarct changes, but doing it too early may not have the changes you want. So 7 to 14 days after the insult is, if you want to do one MRI at that stage, and then you may need to do follow-up MRI depending on the findings and the clinical progress. But always be clear that the MRI abnormality doesn't always translate into clinical outcomes. And at the same time, a normal MRI doesn't mean the clinical outcome will be normal. So when you speak to the family, you have to be guarded. At the same time, you can be as cautiously optimistic as you can, so you don't depress them. But MRI is only reflection. It's not going to accurately predict. So the mild encephalopathy almost always recovers, and that's the reason the studies are difficult for this group. Moderate encephalopathy, if the recovery happens by 7 to 10 days, if the baby is sucking all feeds, there is no persisting seizures, it's a good outcome, and the overall 25% disability. The severe grade 3, when they become comatose for a period of time, it's almost always 100% disability. You do have the grade 2 to 3, where the babies are borderline comatose with persisting seizures, which recover by 4 or 5 days. That's usually little on the higher side, like 50% disability. So to conclude, perinatal asphyxia is still not fully understood. It's a topic of great importance to the practicing obstetric and neonatal staff. And it's very important to remember the medico-legal implications of everything we speak or write in relation to the problem. The parents are anxious at that time, and there is a big medico-legal issue if they don't understand. And we should remember that parents can record information we speak and don't implicate obstetricians in any way. The best way is to say that the obstetric management is best discussed with the obstetrician. So don't go into the details of the obstetric management. Don't write anything that can incriminate your team. So you have to be frank, you have to be open, but at the same time, you have to be sensible and cautious. So with that, I conclude. I'll stop sharing my screen. Thank you.
Thank you very much, Dr. Sridhar, for this concise presentation, for this important topic which we face on a daily basis. We have a time for a few questions. One of the questions about the incidence of asphyxia in relation to cesarean section, delivery, or large for gestational age.
Asphyxia can happen in any setting, and when you have a large for gestational age baby or you suspect there may be CPD, the obstetricians, as I said, in the developing world, they are still hesitant to do cesarean for the reason of cost and accessibility to the services. So if you delay it, you may end up in more trouble. So that's where the obstetric care and the reason for the rising cesarean is the same. I mean, people are worried about asphyxia. You may be blamed later, so you rather err on the side of caution. But it depends on the obstetrician really. And if you have a doubt, I mean, discuss with the family, monitor closely and act quickly. Don't delay if there is a sign that there may be a problem.
But most of the time, as you know, neonatologists and pediatrician, we are involved after the event, you know. So when the obstetrician decide whether they go for vaginal delivery or cesarean section, and you just go to the scene and you are faced with this problem. So, I mean, in case of like large for gestational age, would you recommend to have a cesarean section rather than vaginal delivery?
What we should remember is that the cesarean delivery is not absolutely safe. There are many long-term studies which show that the cesarean sections have impact on the baby's future health. That's why I said cautious assessment, monitoring, and intervene early if you think things are not going in the right direction. I mean, it's a question of ethics as well. I mean, you wouldn't want to do cesarean in a mother who doesn't need it, and you have to give a trial of vaginal delivery or progress of labor. At the same time, if it is a large for dead baby, the way you use intrasinon should be careful. So I agree that the pediatrician will not interfere in the obstetric management, and we want the baby to be safe. But at the same time, we wouldn't want them to do more cesareans, because there are many data which are coming out that cesarean delivery impacts both the mother and the baby, and especially the gut microbiome and impact on the future health. So careful monitoring, early intervention. What is happening in the developed countries these days is a rise in cesarean rate. And obviously this is because of this paranoia that is created. It's a balance. I mean, the obstetric care is a tough field. And obviously the obstetrician is the background, how they train, where they work in, what is the coverage out of hours, everything will play a role.
Another questions about umbilical prolapse and or node, and it has any, you know, critical period, and how would you manage this in relation to asphyxia?
I mean, any sentinel event is an emergency, and this is category 1 or a code. I mean, basically in any hospital, if the mother happens to be in a hospital, it will be a code and acute delivery. But if she is outside the hospital, unfortunately, it will be a stillbirth, most of the cases. I mean, abruption, sometimes they come in labor and the bleeding is happening, and then they are taken to the OT and baby is asphyxiated. So the baby may not die as quickly in an abruption, but a cord prolapse, if they're not treated well, there may be a quick loss of the fetal life. I mean, so it's very important that the obstetric emergencies are dealt with in every ER as well, because these mothers tend to present to the emergency. They should be able to push the cord up, and I mean, you have to have your hand inserted into the vagina to push and take her for emergency. And every hospital has to have a drill where they are able to take the time taken from the coming to the ER to delivering these babies should be less than 20 minutes at the most.
The last question, you know, is there a relation between a mother who has a viral illness just before delivery and asphyxia? If she has a flu or she has corona or whatever?
It's very difficult to answer that. I mean, obviously, it depends on her condition. A viral infection itself may not affect the fetus directly, but if it affects the well-being of the mother, many mothers may complain of reduced movement and so on. So don't ignore the mother who complains of reduced fetal movement. So always assess them and take an informed call. I mean, I cannot answer specifically. Of course, there is increased cytokine response in any infection, and these responses may cause vasoconstriction in the umbilical cord. There is a risk, and especially if the mother is diabetic as well, towards the later end of pregnancy, you have a high risk of stillbirth. So all these have to be balanced, but there is no categorical response that's possible for these questions. So thank you so much for these nice questions, and appreciate the patient listening.
Thank you very much for your time.